I'll share my screen meanwhile.
Recording in progress.
Yeah, we are good to go.
Are we live?
Yes, sir.
Yeah, we are good to go.
Yeah. So good evening, everyone, and good evening to all the faculty members and delegates who have joined today evening in this international speaker webinar on prostate cancer bridging global and national perspectives. So my name is Dr. Ankush Gaikwad. I lead the SSD cluster medical for Agriculture. And on behalf of mCure, I welcome all faculty members and delegates to this webinar. As we know from Globocan data that prostate cancer is the 12th most common cause of cancer in India, with about 40,000 cases per year, and it is an important cause of mortality and morbidity in men suffering from prostate cancer. So in today's session, we are privileged to have our international speaker, Dr. Jason, and our esteemed national faculty for today's event, who will give perspectives on treatment of prostate cancer and different avenues in the treatment for prostate cancer for patients. I'm pleased to introduce our chairperson and moderator for today, Dr. R.K. Shimpi, sir. So, as a director at Asian Institute of Men's Health and Urology at Pune. Thank you, Dr. Shimpi, for joining this meeting today. And also, it's our honor to introduce our esteemed panel who will be participating in the panel discussion and sharing their insights at the end of our talk. We are pleased to have Dr. YPS Rana, Director, Urology, Andrology and Kidney Transplant at BLK Max Super Specialty Hospital, Delhi. Dr. Kishore TA, Senior Consultant, Urology at Aster Medicity, Kochi. Dr. Kalyan Sarkar, Senior Consultant, Urology at Woodlands Hospital, Kolkata. Dr. Amandeep Arora, Assistant Professor in Uro-Oncology at TMH Mumbai, and Dr. Neeraj Rastogi, Director Radiation Oncology at Medanta. So I would like to thank all our faculty members and panel members for sparing their time and joining today in this academic webinar on prostate cancer. Also, I'm very honored and pleased to introduce our guest international speaker for today, Dr. Jason Hafron. Thank you, Dr. Jason, for joining today. Dr. Jason is a professor of Department of Urology at William Beaumont Hospital, Royal Oak, Michigan, United States of America, and he's Chief Medical Officer at Michigan University of Institute of Urology, Medical Director of Clinical Research, and Co-Director Clinical Board at Solaris Health, Florida. Dr. Jason has over 96 publications to his credit, 4 book chapters and 158 posters, and has received more than 50 research grants and have contributed to many clinical projects in urology. Dr. Jason holds prestigious place at editorial boards of various journals, including International Urology and Nephrology Journal, Advances in Urology, Urologist Care in Cancer Care, and Urology Times. So I'm very pleased to introduce Dr. Jason, and followed by his and with request to proceed with his talk on the very important topic for today's webinar. So I'm handing over the session to Dr. Jason Hafron for his talk.
Yeah, thank you, Dr. Ankush, and thank you so much for this opportunity to speak to all of you. It's really a privilege and honor to represent U.S. urology and our continued partners with our Indian urologists. So really a pleasure and honor and exciting to share our experiences and hear about your experiences. What I want to talk to you about is the role of androgen therapy in the management of prostate cancer. I am working for mCure and Tolmar. Tolmar is the equivalent of mCure in the United States. This presentation is being funded by them. The agenda today is we're going to focus on ADT. It is foundational therapy in the management of advanced prostate cancer. I'm going to talk to you about how we are trying to optimize ADT treatment within our practices. And then the use of ADT in, the different stages of prostate cancer. In this area of the different stages, we're seeing a massive explosion and a paradigm shift in how we manage these patients than we just did a few years ago. And then I think we can't talk about advanced prostate cancer without talking about PSMA PET imaging. This is disruptive technology that's changing how we manage this disease, leading to other things like metastasis-directed radiotherapy, and introduce all of the radioligand therapy activity that's going on across the U.S. If we're talking about ADT, we have to go back to Dr. Charles Huggins. Dr. Huggins was a urologist in University of Chicago. In 1966, he won the Nobel Prize in medicine for his discovery that prostate cancer is hormone dependent. Dr. Huggins was, ahead of his time, but he was also prophetic at that time to notice that despite the regressions of great magnitude, it is obviously that there were many failures of endocrine therapy to control the disease. So in 1966, Dr. Huggins realized that ADT is good and helpful, but it's not the end-all be-all, and that there is additional therapies or treatments that will be required. And what I'm going to highlight is what we are doing to help, augment or improve the care and the outcomes with ADT. ADT monotherapy for metastatic prostate cancer has been foundational, but it has been limited to poor clinical outcomes. It's not, it's good, but it's not perfect. And this is kind of what Dr. Huggins was talking about. The new standard of care for advanced prostate cancer is ADT as the foundational treatment, but in combination with other therapies, other novel hormone therapies, which I will get into. And ADT alone is only recommended today for adjuvant therapy for radiation therapy. There is no indication for ADT monotherapy outside of radiation at this point. That being said, here's the current landscape of all the therapies that are available. This is what we commonly call the prostate cancer roller coaster slide. It starts with localized disease and then eventually progresses to advanced disease and metastatic disease. Based on current FDA guidelines, I don't know the Indian guidelines and requirements, but this is how we look at it, what's available and how we manage this. And this is a good summary. I think the key point for all of this, regardless of whether you're using Zytiga, Xtandi, or Erleada, or immune therapy, ADT is the foundation of care. We never stop the ADT therapy. All the studies and all the treatments, we use that in the management or in combination with the patients. I don't have to go through this, but we all know that this is the mechanism of action. There's a variety of different ways we can disrupt the androgen pathway or inhibit the androgen pathway. It can be with the LHRH agonists, and these are the 4 agonists that are available. And then the antagonists, degarelix and relugolix, are the 2 antagonists that are available. And then here are all the orals. We start with the CYP17 abiraterone inhibitor. First generation bicalutamide, nilutamide, flutamide, really no indication except for flare to be used. And then all of the second generation androgen-directed therapies, enzalutamide, apalutamide, and darolutamide, which are essentially have evolved to the standard of care in the management of advanced prostate cancer. So how do we optimize ADT therapy? This is a study that I was one of the co-authors on. We looked at over 80,000 injections across the United States. We looked at oncologists as well as urologists, and we looked to see if the patients were getting their injections on time. And what we found was that 84% of the injections given in the United States were actually late. So in US urology, US oncology, we're not doing a great job with these injections. The patients are not getting them on time as prescribed in the trials or as prescribed per label. And what we saw was that when they don't get these drugs on time or they're delivered late, we see breakthroughs. And we know that testosterone breakthroughs are associated with poor outcome, poor survival, and increased hospitalization. And we see breakthroughs at 15% greater than 50, 31% greater than 20. So the implications of this is that as a urologist, how do we message this to our partners and to the field is that you have to give these drugs on time. You can't delay. You have to give it per label. And the other thing that we struggle with is that you have to measure the testosterone. Just measuring a PSA is not adequate to make sure that these drugs are effectively working. T suppression has to be documented. In our practices, we check a PSA and a testosterone every 3 months for a patient who is on therapy. And then we are very, adamant or very strict on making sure that these patients get their drugs on time. The other thing is with these new radioimmunoassays, we can actually measure the exact testosterone. We shoot for less than 20. That's, significant testosterone response. That wasn't always available when these drugs were initially introduced. And that's why the guidelines are a little bit of a mess right now. If you look at multiple guidelines, the Bethesda consensus, the European guidelines, the Canadian guidelines, they all recommend a testosterone less than 20. And EAU updated that most recently. The FDA still uses less than 50 as their target, and T less than 20 is a secondary endpoint or profound testosterone suppression. AUA, American Urological Association, the National Cancer Institute, the NCI, NCCN guidelines haven't been updated, but I think generally in the practice of the United States, most people are shooting for a T suppression of less than 20. The other thing that's very helpful in our practice is the 6-month ADT injection. It's our preferred treatment delivery. We've shown in multiple studies, you can see the references that 6-month formulations are just as good as shorter acting formulations, but they have an increased advantage. They can reduce the number of office visits. The patients don't have to come back as much, which is very helpful in a busy clinic. And what we've shown is that because you're only doing it twice a year, you may achieve better T suppression and less testosterone breakthroughs. So we generally prefer the 6-month. We know it's consistent. We know it's on board. We don't have to bring the patient back and forth. I was a part of this study where we looked at 6-month versus the other month suppressions. We saw an improvement, definitely the 1-month suppression. There's no, you're going to have a lot of late injections. We saw the least number of late injections with the 6-month, and that's kind of how most people have adopted. It's not in the guidelines, but we see less late injections and breakthrough with 6-month. I'm just going to switch gears and just run through ADT kind of, high level, where we're at today and how we look at ADT. Is there a role for ADT for high-risk localized prostate cancer? And this is, sorry, it's US-based, but this is, I don't have international numbers, but in 2024, there'll be 300,000 new cases of prostate cancer in the US. About 15% of those will have high-risk disease. High-risk disease per NCCN guidelines is Gleason 8 or higher, T3 PSA or higher, or PSA greater than 20. And approximately 45 to 65% of those with high-risk disease will recur within 5 years after undergoing a radical prostatectomy. What we looked at is apalutamide, again, a selective androgen receptor inhibitor and approved for non-metastatic castrate-resistant and metastatic castrate-sensitive prostate cancer. And what we wanted to do, what we did was, and I'll show you the data, is a phase 2 trial that looking at apalutamide plus ADT 6 months prior and 6 months after radical prostatectomy for high-risk local disease. Can that improve outcomes? Here's this trial design. This is what I presented this at the podium last spring for the American Urological National Meeting. It did got a lot of press. It did get a lot of interest. Basically, again, we took high-risk localized prostate cancer. We gave them apalutamide plus 82. It's a phase 2 trial, and then we followed them. We also did a sub-study, not really pertinent to the point of my discussion, but we added relugolix plus apalutamide to make sure there was no disruption of testosterone. The bottom line here is that the confirmed biochemical-free survival rate, phase 2 trial, BCR was our endpoint at 24 months was 100%. Just to keep this in perspective, the published literature from Italy in this patient population, biochemical-free survival rate is 76%. There's an ongoing trial called the Proteus trial. I strongly encourage you to follow that trial because that will be a game changer. Their Proteus trial endpoint is going to be MFS, metastasis-free survival, and if that's positive for high-risk disease, I think what we're going to see, obviously pending the data, is that ADT plus apalutamide may become promising or potentially standard of care in that patient population. The criticism we got was, well, yeah, of course they're going to do well because their testosterone suppressed. But 76% of the patients had complete testosterone recovery greater than 150 at 12 months. 95% of them were not castrate resistant. So there was recovery of testosterone, and there is some signals to say that there may be a role for ADT plus apalutamide in this patient population. I'm going to switch gears here. So that's new. I guess the bottom line there is wait for Proteus trial to come out, which probably will be out in late 25. We'll have the results. The data's been locked, but it's a large 1,500 person international trial. So let me just talk a little bit about metastatic castrate-sensitive prostate cancer. This is an area that's been booming, very active. This is our growing area. For us, we follow the NCCN guidelines. This is the most recent update from April of 2024. I think the key point here, which you guys probably already know, is that we divide the patients based on the charter data from England, whether they're high volume or low volume. That's determined by metastatic sites. If they have greater than 4 metastatic sites of bone, they become high volume. If they have less than four metastatic sites, they're considered low volume. I think the key here is, I'm not going to go through each one of these, but basically, again, ADT monotherapy is no longer accepted. ADT plus combination of abiraterone, darolutamide, apalutamide, enzalutamide are all recommended for high volume and low volume. And then we'll talk a little bit about the management of metastasis. How did we get there? How did we get to these guidelines? And this is basically the literature or the history of the literature or the trials that were performed to say that the role for novel hormone therapies, again, started with chartered, and ASCO released it in 2015. Most recent ones, which we'll talk about, were Piece 1 from Europe and Arisons from Bayer International. But here you can see, and I'll go through this. This is why we no longer use ADT monotherapy, because all of these trials have been positive. These are the trials that lay the foundation for the current NCCN guidelines that we all follow. Again, here's how we define low volume and high volume. And mostly we use the charter data. Basically, 4 or more bone sites is high volume or visceral mets. Low volume is less than 4. There's also the Latitude trial, another international trial that used abiraterone. They use low risk versus high risk. And then high risk is 3 or more bone lesions, visceral mets, or Gleason greater than or equal to 8. Some technical things, but I would say based on the guidelines and based on most discussions, we've kind of fallen away from the Latitude low risk, high risk, and we're looking at high volume versus low volume. Here's the charter data. This was the first trial to show that ADT plus docetaxel improved overall survival. The key here is that we only saw the effect in the high volume disease. Low volume disease, based on, you can see these Kaplan-Meier curves, and the hazard ratio did not show any benefit. So initially, we did ADT plus docetaxel was the standard of care. ADT plus docetaxel no longer is the standard of care, and we've evolved. The only role for docetaxel is in triple therapy or oral therapy failure. And then here's the latitude data. This was abiraterone for plus ADT. And, bottom line here is significant. The hazard ratio 0.66, curve looks solid. Abiraterone plus ADT significantly improved the primary endpoint of overall survival. And then we looked at ARCHES, which is enzalutamide. Enzalutamide primary endpoint here was radiographic progression-free survival, very positive hazard ratio 0.39. Overall survival was a secondary endpoint, hazard ratio 0.66. So ADT plus enzalutamide in metastatic castrate-sensitive prostate cancer, high volume, low volume, primary radiation, primary surgery, doesn't matter. There's an improvement in rPFS as well as OS. Enzamet, again, this is just more of the same, just going through that, didn't matter how they presented, but if they have metastatic disease, low volume, high volume, and whether they got a concurrent docetaxel, also had the concurrent docetaxel had no impact. But again, improvement in rPFS and OS. Titan was the apalutamide trial for metastatic castrate-sensitive prostate cancer. Same old story. rPFS is significantly positive. Hazard ratio here was 0.48, early separation of the Kaplan-Meier curve. And then the overall survival here too, secondary endpoint, also showed benefit with a hazard ratio of 0.67. So very similar, enzalutamide, apalutamide, very similar drugs, very similar outcome. I think the message here is that when you have a metastatic patient, the ideal or standard of care is ADT, Eligard, plus an oral therapy. And here's just a summary of the three major trials that are all guideline registrational trials that led to the approval and led to the current standard of care. And you can see that why no longer monotherapy is an acceptable option. ADT plus oral novel hormone, ARPI, whatever you want to call it, all are significantly positive. The newest that just came out, not just came out, maybe a year or two, maybe 2 years now, is triplet therapy for metastatic castrate-sensitive prostate cancer. So triplet therapy is what if we use ADT plus an oral plus chemotherapy? Is that better than doublet therapy? The PEACE-1 trial, again, this was brought by Dr. Fiazi from France, a European trial. It was a 2x2 factorial design, 1-to-1 randomization, where patients got standard of care, which is ADT and docetaxel. So at this time in Europe, standard of care, when this trial was done at this time point, standard of care is ADT plus docetaxel. The other group that they compared it to was ADT plus docetaxel plus abiraterone. And then the other two bottom cohorts, I'm not going to really talk about. The data was just released this summer, and this was positive too. I'm not going to talk about it today. The point of PEACE-1 is that ADT plus abiraterone plus docetaxel, triplet therapy, chemo ADT, and oral ADT all led to significant improvement in death. There was an 18% reduction of death with a 1-year survival benefit. Hazard ratio 0.82. Post hoc analysis, high volume, there's a 25% reduction in death. What also stands out, this is the first time, I point this out, this was the first trial that we've ever seen in prostate cancer that reported a greater than 5-year median survival. So very powerful. We took a disease that had a median survival of 2 years with good trial design commitment by the urologists worldwide. We're seeing that the reported median survival in these patients is going out to 5 years. So kudos to everybody. Kudos to urology as a field to keep pushing this forward. This was followed up by the Arisons trial. This was a Bayer trial. Again, similar to PEACE-1, but only a two-arm trial, double-blind, placebo-controlled. metastatic hormone-sensitive prostate cancer, 0 to 1 performance status. They stratified based on TNM staging, M1A, M1B, M1C, ALK phos levels, but basically patients got ADT, and then they got docetaxel, and then the randomization was after ADT, after docetaxel. Patients were randomized to placebo versus darolutamide. Darolutamide is Nubeqa. Endpoint here was OS, overall survival. Here's the data, basically very positive. Triplet therapy improved overall survival compared to ADT plus docetaxel. So there is a benefit for triplet therapy. I don't think I have they did a post hoc analysis, and most of that benefit, I don't have the slides. Most of that benefit was seen in the high volume patients. Arison's 86% of these patients were high volume, very heavy disease burden patients. And in that patient population, I say generally in the US, anyone walks in with de novo, high volume, who's chemo ready or chemo fit, they would get triplet therapy. And that's, again, ADT, docetaxel, plus an oral agent, darolutamide or abiraterone. So in summary, I'm sorry I'm giving you a lot of information. Why do we do dual agent therapy? And this is kind of a slide I put together, is that when you pull the major trials, ADT alone, you see an overall survival of less than 3 years. When you add docetaxel, that gets to about 40 months, maybe 4 years. When you add abiraterone based on Latitude Stampede, you get that out to 50-ish, 56. Titan, we're seeing 50 months, But then when you take it even further and you add triplet therapy, piece one, we're seeing, median overall survival of 61 months. Arison's hasn't reported their overall survival. It hasn't been reached yet. Their median hasn't been reached yet, or I haven't seen it yet. But again, combination dual agent therapy, ADT plus chemo plus oral, leads to the longest reported overall survival. Reality is, this is a publication I was involved with, is that, this was from 22 based on 21 data. Most urologists and oncologists aren't following the data. It's not being widely adapted. So as urologists and oncologists, what we promote, it got a lot of through education, through grants, like through mCure, is that, proper management is using, following the guidelines. So we have a lot of work to do. I know in the US, I don't know the Indian data, but US, we're not there yet. And it's a constant struggle to get urologists and oncologists to use, doublet and triplet therapy. I just want to talk, and I know we have a radiation oncologist on the panel, which is great, because this is for, I'm sorry, I don't know your name, but the radonc is that in patients who have low volume metastatic disease, there is data to show that we should radiate the primary, we should radiate the prostate, and use it in combination with abiraterone, and that's based on Stampede-H. In the US, we have an ongoing trial, SWOG 1802, which we're looking at, is there a value for doing a radical prostatectomy plus abiraterone plus docetaxel in patients with low volume metastatic disease. I think today, when we find patients with low volume metastatic disease and they haven't had their primary or their prostate treated, we try to get them treated based on the Stampede data. And here is the data that was published that led to the NCCN guideline, is that in this panel here, we didn't see any difference in the complete population, but when you look at those with low metastatic burden, you do see an improvement in overall survival. And we also see progression-free survival and low metastatic burden. So this is the literature. This is the data that supported the guideline and our standard of care for management of these patients. Metastasis-directed therapy, again, glad we have a radiation oncologist to discuss this, but this is one of the hottest areas right now. This space is exploding. There was a lot of great abstracts at our AUA in the spring at our national meeting. And there's a couple terms that I think we have to know. how you can apply metastasis-directed therapy in oligometastasis. You can do it to all the lesions. You can do it to a recurrent lesion. You can do it to a progressive lesions, or you can do it to symptomatic disease in widely metastatic. So I think the terms and how we look at this, we need to, define and refine. And as we look at patients, we got to understand their metastasis and where they are. There's a lot of activity. These are probably the 4 biggest trials that have gone on. As you can see, they're phase 1 and phase 2 right now. STOMP and Oriel, Popstar, and mCRPC, which is Memorial, is the Cancer Center in New York. But here's what they looked at. The bottom line with these trials, and I pulled STOMP and Oriel, that metastasis-directed therapy resulted in improvements in PFS, progression-free survival over observation. You can see pretty strong signals. Phase 2 data, phase 3 data is coming, but I think in what we're seeing a lot in everyday practice is a lot of people in our community and across the country are chasing a lot of these lesions and doing stereotactic radiation right to the metastatic site. What about radioligand therapy? Again, another hot area. I don't have time to go into detail, but radioligand therapy is PSMA-directed radiation. Right now, it's mostly beta particles, but there's a lot of activity looking at alpha particles. But again, the point of this slide is that people are combination radioligand therapy plus or minus stereotactic radiation therapy to treat metastatic castrate-sensitive prostate cancer. Here's a trial, the PSMA addition trial. This is ongoing. It hasn't read out yet, but this is just a taste of where we're going. This is not standard of care. This is just a trial. But basically, patients who have metastatic castrate-sensitive prostate cancer based on PSMA PET imaging, any volume was allowed. These patients got radioligand therapy, Pluvicto, or lutetium, however you want to call it, with enzalutamide. So this trial was the trial was enzalutamide or any novel hormone plus or minus lutetium. Again, exciting, preliminary reports. We'll just have to wait to see what the data shows. But this is kind of appealing and potentially a way where we combo ADT plus enzalutamide plus lutetium to manage metastatic castrate-sensitive prostate cancer. We all await for PSMA addition to come out. Oligometastatic disease is obviously an evolving space. We don't know exactly now. The literature's coming in, and we'll see in the next couple of years. How many lesions can we treat? Where can we treat? Is there a difference between de novo or synchronous or oligo-recurrent, metastatic, oligo-progressive? We don't know. Has the primary treatment treated? We know based on Stampede, you can treat the primary, but that's a question that hasn't been fully answered. And then if we are doing metastasis-directed therapy, there's some literature for Stampede, but not well vetted, is that do we need to apply ADT plus a novel hormone? And then we don't really have any data right now that it impacts overall survival. It's coming, but the point of this slide is these are a lot of questions that I encourage you to, that we'll see once these trials read out. The phase 3 trials are being done. And then most recently, what's the role of the radioligand in this space? So I think generally speaking, we are shifting to a combination of XRT or radiation oncology to do metastasis-directed therapy, radioligand therapy in combination with these agents, and more to come. But I think based on the amount that's being invested in research trials, we'll see more and more of this becoming standard of care as the data accumulates. mCRPC, this is the NCCN guidelines. This is what we follow. We just, it's basically a long list of every available option drug. I think the way that we look at mCRPC management is that this concept of therapeutic layering, that we start with supportive care is obviously, but I think the key here is we start with ADT, and then we will add all of these therapies on. Good metastatic castrate-resistant prostate cancer care is offering patients every line of therapy. If they don't get docetaxel, if they don't get Provenge, if they don't get a PARP inhibitor and they qualify, these patients, yeah, that's not good mCRPC care. And when I look at charts, I do, evaluate quality. I want to see 3, 4, 5 lines of therapy. To me, that is how good metastatic castrate-resistant prostate cancer is given. In our practice, we start with ADT, and then we will use Sipuleucel-T. It's the first immunotherapy. It was approved in 2010. It's basically an immune reaction. We take the white blood cells and the antigen-presenting cells out of the body, reprocess them, resubmit it, and stimulate an immune response. These are the 3 trials that have led, the IMPACT trial led to the approval. PROCEED is a phase 4 trial. PROVENT's an ongoing phase 3. But basically, we start in asymptomatic, minimally symptomatic patients with immunotherapy. Another option, too, I'm just going to run through these, is radium-223. It's an alpha-emitting particle. It's not targeted, but it's a radiopharmaceutical that delivers a low alpha particle to the bone. This was approved. It's for metastatic CRPC. This was approved based on the ALSYMPCA trial. There's now some combination trials that are going on. The most recent trial that's coming up, I don't know, I have a slide on it, but there's a trial that has read out. It was positive. Data hasn't been released, but enzalutamide plus radium in mCRPC. So a combination trial where you could potentially, oh, here it is, sorry. This is piece 3. Piece 3 is positive. It's been presented. The data hasn't come out, but the way the U.S. companies will say it's positive, but they won't tell us. It hasn't been FDA approved. But the bottom line is that enzalutamide plus radium is going to be an option. Most likely it's not all there yet, but this is how it starts. That it will be an option for metastatic castration-resistant prostate cancer. Obviously, patients who are bone heavy, this will be an important innovation or option for us. Pembrolizumab, Keytruda, probably one of the greatest cancer drugs in the 21st century, has 27 indications, like multiple 8 or 9 category 1 indications across the spectrum. As for prostate cancer, we're mostly using MSI high, DMMRs and tumor mutational burden high patients. And when you find that in these patients, they respond great. It's usually late-stage prostate cancer, but these patients actually do very well. Obviously, you have to find these, biomarkers or based on somatic testing. Lutetium, we touched on. Lutetium, is a beta particle that's targeted therapy. It basically targets PSMA receptor. It's 6 infusions, and based on the VISION trial, we saw lutetium plus standard care versus standard care alone. We saw a significant improvement in overall survival. We saw a PSA response and radiographic progression-free survival. So lutetium, again, is post-chemo in mCRPC, second-line therapy for post-chemo, but option for patients who have a PSMA positive scan and can tolerate the treatment. PSMA-4, Splash, Eclipse, these are all the pre-chemo trials that are ongoing. Or actually, yeah, most of them are PSMA-4 is awaiting FDA approval. PSMA-4 was the first. We see this is going to be interesting. It'll be interesting to see how the FDA, if they approve it. But we see a robust progression-free survival improvement here. You can see it here. But when you look at the overall survival, hazard ratio, I don't see it, but the hazard ratio is like 0.98. Oh, here it is, 0.8. So you don't see a robust response. It's actually, I don't know what data this is. This is older, but what they submitted was 0.98 hazard ratio. Crossover was 84%. They submitted at 78%. So overall survival may be a trial design flaw. Definitely RPFS, but we'll see. This will read out later this year, and we'll may potentially have lutetium pre-chemo. Combination therapy also, obviously a lot going on in this slide, but we are also doing a ton of combination trials with radioligands. Again, the theme is radiation oncology and advanced disease has a significant role, whether it's stereotactic or whether it's use of the radioligands. Here's just a list of from the National Cancer Institute of large trials that are going on. I think the most interesting one trial is ENZA-P phase 2 trial, small study, but what they looked at is enzalutamide versus enzalutamide plus lutetium. And this trial has read out, and I showed the other trial, the piece 3 is the phase 3, but here's the phase 2 data, very positive, as you can see. So, we'll see where it goes, but very exciting. And then PARPs, you guys all know PARPs. PARPs play a role. Here's the mechanism of action of PARPs and why they work. In order to qualify for a PARP today, and that may change in the future, is you need to do germline and somatic testing. Germline is obviously what you're born with. Somatic is as the tumor develops. Germline is blood or saliva. Somatic is tissue. Germline has significant implications because it can affect the family as well. And then somatic has implications because it can be applied for targeted therapy. So here are the 3 PARPs that are currently approved in the US for first-line mCRPC. We have olaparib with Abi, talazoparib with enzalutamide, and niraparib with abiraterone. You can see their indications, what mutations are required to qualify. These are just FDA US requirements. But here's the data. I mean, look at PROPEL was the study, hazard ratio 0.24, hazard ratio 0.45, hazard ratio 0.53. Huge impact. I mean, I think what the key here, the message here, just looking at the hazard ratio, is that you have to find these patients, you have to test for these patients, because if you do have one of these patients, they will respond beautifully. If you don't treat them with a PARP inhibitor, they will fail quickly. So kind of interesting. And then just to be complete, second line, we have 2 PARPs approved, olaparib and rucaparib. Those are post-chemo failures where you could use a PARP. Imaging, again, imaging is specific conventional imaging, CT and bone scan. We use bone and CT. I would say most of us are now evolving to PSMA, PET imaging. It's quickly evolving to the new standard of care in patients with prostate cancer. Very expensive, but very, very good technology. PSMA PET is based on the PSMA transmembrane antigen. It's on the outside of the cell. It's about 1,000 times more significant in prostate cancer. We have currently 4 agents approved in the US. You can see them there: Illuccix, Plarify, Locomets, and Posluma. We have 2 F18 based and 2 gallium based. Not much difference, but I think for us, we just try to get these patients tested and get the insurance companies to pay for it. Generally speaking, there's 2 patients that qualify for PET imaging based on NCCN guidelines, is in men with newly diagnosed of unfavorable intermediate or higher. So that's for initial staging. And then PET imaging is approved in any patient who has recurrent disease or rising PSA after treatment. We basically try to PET everyone we can. I don't have a lot of data on it, but it is significant. So a lot of times, a lot of the US urologists will say, this is stuff for the oncologist. We don't need to worry about it. But when you look at it from the large, 7 international markets, unfortunately, we don't have India wasn't included in the study, sorry, is that this field of prostate cancer drugs and the treatments is going to basically triple over the next decade, and it already is. So I think as urologists, whether you treat these patients or not, we need to utilize or get these patients to be treated with these therapies, because as you can see, they're having a significant impact on their survival and their quality of life. So in conclusion, ADT is foundational therapy for all treatments. Like I said from the beginning, we never stop the injections. We never stop the ADT. On time is critical with injection therapy. It's a challenge for us in the US. We have to do better. Monitoring the testosterone less than 20 is critical. We like to see single-digit testosterone levels. And like I showed you and kind of just gave you a taste, it's a lot of information. The good thing is there's a lot going on, is that ADT is being used in combination with multiple agents, multiple modalities. And what we're seeing is significant improvement in overall survival so that we can take basically, I don't know, maybe I'm thinking a little bit, but a terminal disease and extend these patients' lives to make it hopefully a chronic disease. So again, thank you to mCure. Thank you for this opportunity. That's the end of my talk. I think we're going to open it up to a panel. I'll turn it back to you, Dr. Ankush.
Thank you so much, Professor Hafron. It was a very comprehensive talk covering not only the aspect about ADTs, but also very different aspects about biomarker testing and newer advances in imaging and one of the interesting clinical trials
sure है मैं बाहर खड़े होके ना क्वेश्चन आंसर होंगे 10 मिनट में
on high risk non-metastatic prostate cancer and the future triplet studies and various aspects. So thank you so much for your elaborative talk. And now I would request our esteemed faculty and our moderator for today, Dr. R.K. Shimpi sir, to proceed with the panel discussion. So over to you, sir.
Yes. Good evening to you. Can you hear me?
Yes. Yes, sir.
Yeah, good evening to you. It was an excellent presentation by Professor Hafron, and I think you have covered practically every aspect of the prostate cancer. I have a few questions for you. What is the short life of the radium-223? And how fast it has to be administered?
It's very short. Radium-223 is an alpha particle. Half-life, I think, is less than a day or two. So it has to be administered very quickly. But being an alpha particle, it's actually very safe. The patient's not radioactive. And literally, you can take a piece of paper that will block the alpha particles from being spread. So it's a nice agent because it's not like the old beta stuff, which had a lot of side effects, a lot of anemia, a lot of complications. The alpha particles are, I don't know the exact half-life, but it's better, much better tolerated.
Okay. And which biomarkers are you routinely using for recurrence?
PSA. I mean, we follow PSA, and then if the PSA goes up, we use a lot of PET imaging. So I don't know what the availability of PET imaging, and this has just come over the last 2 years. So that's coming pretty. It's just was approved in the U.S. 2 years ago. But the trajectory and the utilization for PSMA PET imaging is just it's going up. It's doubling every year that we see data on. So 3 or 4 years ago, I think it was like 50,000 scans done in the U.S. And now it's up to almost they're predicting 1 million scans, and that's over 3 or 4 years. That's like an insane amount of ridiculous amount of utilization. And because of the PET imaging, we are evolving, which is the theme too, using radiation metastasis directed therapy to using these radioligands because we can see the disease, we can see microscopic disease that you can't really see with conventional imaging.
Yeah. Okay. Any role of TKI in cancer prostate?
TKI? Not tyrosine kinase inhibitors? No, I've never seen I've never seen a trial positive. I know it's not in the guidelines. I haven't seen, there may be some phase 2 data somewhere, but I've never seen a phase 3 trial, and it's not in the guidelines.
Okay. All right. So we'll start with the panel discussion. And yeah, do you have the slides, Dr. Gaikwad? Can you share the slides?
Okay, yes, I can share. Yeah. Give me 1 minute.
Good evening to everybody. Dr. Vijendra, Sagar, Neeraj, Dr. Kalyan Sarkar, Dr. Kishore, and Dr. Arora, and Dr. Rana.
Yes, sir.
Can you share
Good
the
evening.
slides, please?
Yep. I hope my slides are visible, sir.
Yeah, there is.
Yeah, sure.
Next slide, please. So the first question is the imaging techniques considered in your patients, especially how it has impacted the non-metastatic CRPC diagnosis. Do you want to talk, Dr. Hafron, sir?
Yeah, I mean, non-metastatic.
This, I think you have
Yeah.
covered this.
Yeah, I mean, with PET imaging, it's significantly reduced this space. And if you look, there's data from Germany that when they look at patients with conventional imaging, the majority of them, when they re-PET those patients, have metastatic lesions. So it's a very significant number, 70 to 80% who are conventionally negative are PET positive. So this space is shrinking. It's not a big space. This is a disease category created by FDA to get these drugs approved.
Yes. Any comments from Dr. Neeraj?
I think PSMA PET is the standard in the imaging technique, as Dr. Jason has told.
What's the standard?
Okay.
Oh.
Any role of the radioactive choline PET scan in this group of patients?
Which PET scan?
Choline PET scan, 11C.
Choline. Oh, choline. No.
Supposed to be more sensitive to detect micrometastasis.
Yeah, the problem with choline is it's not as stable. It's very hard to use there's 2 centers that use choline, the Mayo Clinic and in Texas, one of the clinics there, but it's not a stable molecule. You can't produce it at a high level. It's just not a good commercial product. So I don't know the half-life, but I know it's a very unstable, molecule. And the gadolinium and the fluorine are much better. So we moved away from no more choline.
Suppose you have a patient where the PSA level is 0.2. Yeah. Suppose you have a patient with a PSA of 0.2 nanogram per ml, which is consistent for almost 6 months to 1 year. So what investigations you will do in this particular group of patients, and whether you should treat this patient, or whether it is because of the benign tissue left at the apex?
They've had a robotic prostatectomy or prostatectomy, and they're at 0.2. So what we would do in that patient population is we would do a PSMA PET to make sure there's no evidence of metastatic disease. Positivity rate of that PET scan will be about 30 to 50%. And then we would offer them salvage radiation, even if the PET's negative. If the PET's positive, we would treat the site. And then typically based on the radicals trial, we would give 4 to 6 months of hormones with the salvage radiation.
If the PSA is persistently less than 0.2, if the PSA is persistently less than 0.2 nanogram per ml,
if it's I thought you said if the PSA gets if the PSA is less than 0.2, we don't treat it. But we don't. But if we see anything going up from 0.1, we don't want to. We want to treat them at 0.2 or 0.3. So if we see it going from 0.13 to 0.17 to 0.18, they're showing signs of failure. We will PET them and potentially treat them because we don't want to wait to that PSA and that's the radicals trial and the raves trial, that if you don't treat them when their PSA is less than 0.5, ideal is 0.2 or 0.3, their outcome is significantly compromised.
yes. Okay. Dr. Kalyan, any comments on this?
Thank you, Dr. Jason. Interesting presentation, and hi to everyone. I have a question. Is a contrast MR helpful in these situations where you're suspecting recurrent disease in the pelvis and the PET is negative? So would a contrast MR be a good investigation here? Useful?
The radoncs do get it quite frequently. So they will get it for planning purposes, and then they'll decide if they want to boost. They use a lot for if they're boosting a site or an area. So there definitely is a role for contrast MRI. We frequently will get it with the PET, especially if we're going to do salvage radiation.
Dr. Kishore, what is your opinion?
You mean regarding the PSA? Actually, I treat the
mCRPC, yes.
Yeah. I mean, I treat the PSA much earlier. Like I don't allow the PSA to climb up to 0.2. So I treat somewhere, if it's a progressive rise in PSA, even less than 0.1, I do that. So if there is, I think that would be the most effective way to treat if there is a possible local recurrence. And in my experience, the PSMA PET scan does not pick, the metastasis well with such a low PSA. The lowest I have had the PSMA PET scan picking up is 0.315, where there are solitary mets. But there have been cases with PSA between 1 and 2 where there are no mets. So, if the PSA is really high, if the nodes are positive, then I don't give salvage radiation. But there is no evidence in the pathology for extraprostatic spread. And since the PSA is very low, I go for salvage radiation and a couple of doses of hormone.
Yeah, and I agree with that. I mean, we've gotten very aggressive, I think very aggressive. The lower you treat it, the better the patient will do. And, when they start rising in that point, when they start going above 0.1, that's when we're talking to the patient about failure. We're getting them to see the radiation doctors. We order the PET, positivity rate's low, but you sometimes get surprised. And if you look at the published literature, positivity rate at that level is like 30% is based on the trials. So it's usually, to your point, it's usually going to be negative.
It's quite low in our experience. It's been really low. Even with a very high PSA, like 1, 2, sometimes it comes to be negative. So that is quite interesting for 30%. Yeah.
Okay.
Yeah,
Yes.
just like there's.
So let's go to the next question.
Sorry. Go ahead.
Let's go to the next question. Can you change the slide, please? Can you change the slide? Okay, so what are the routine biomarkers in prostate cancer? In which patient you will estimate, what stage you will do it, and which test? Dr. Rana?
So, so routine biomarker in my practice is the serum PSA only, and in the follow-up thing. So, but for the diagnosis thing, sometimes this PSA free and total ratio and PHI. I actually we did a thesis also on PHI. It helps in identification and in limiting our unnecessary biopsies also. So free and total ratio and PHI, these are two things which we are using in our clinical practice nowadays.
That's routinely done?
Sir, yes, we have found it useful in identification and doing the prostate biopsy and negating the negative biopsies initially. But for follow-up, this PSA total, and once in 3 months, we are doing PSA in our patient for initially 2 years. If the disease is stable, it's less than 0.00 range, then after 6 months, once in 6 months, I'm following those patients. And as we discussed earlier in the last question, I treat the patient early with the adjuvant cell-based radiotherapy if there is the slightly increase in the PSA, so that the disease is under control for a longer period. That's my take.
Dr. Arora? Hello? Which routine biomarker you use in this group of patients? Okay. Jason, what is your protocol for this particular group of patients?
So where we've gone now is in a patient with a pre-cancer diagnosis, patient with an elevated PSA. Prior to biopsy, what we recommend, I wouldn't say it's being done widely, but where we're trying to get to is that the patient either has a biomarker or a multi-parametric MRI. Okay. And there are 6 currently recommended or biomarkers that we would consider, and they're mentioned in the NCCN guidelines. One was just mentioned, Phi is one of the 6. ExoDX, which is a urine-based marker. MIPS or MIPS 2.0 urine-based marker. IsoPSA is also a very good marker. And then the 4K, I don't know if you guys have, has been around for a while too, as a serum-based marker. So those are the biomarkers we use, or an MRI prior to biopsy. Once the patient's diagnosed, we have now four genomic classifiers or biomarkers that will help us decide on how to treat the patient. So we have the Polaris test made by Myriad. We have Decipher. I'm sorry. You want me to stop?
Yeah, and what are the biomarkers used for prognostic purpose?
The 4 that we,
that is,
yeah,
the
Polaris.
Decipher and the Polaris.
Yeah, we use for prognostic. Yeah, Polaris, Decipher, Oncotype DX, and then the most recent one is Artera AI, which is based on AI technology. That's just coming to market and just getting used. And we use these classifiers, one, to determine if we should treat the patient, whether they should be treated or placed on active surveillance. And then what these markers, Decipher, Artera, and Polaris also help is in the intermediate risk patient, whether that patient needs to be treated with androgen deprivation therapy.
Okay. And this BRCA1, BRCA2 mutations that you do routinely?
No, the germline testing is only in patients with metastatic or N1 disease, patients with a family history, or patients with high-risk disease. Gleason 8, T3, or PSA greater than 20 qualify for germline testing.
Okay. Anybody wants to add in this algorithm? Dr. Kishore? Do you do any of this routinely?
Yeah, I just go with PSA and then jump to MRI because that is more economically viable because of economic reasons. So I don't do much of a markers, but I feel that definitely it has got a lot of potential. Yeah.
Okay. Anybody does super selective PSA where the levels can be not 4? Anybody does the super sensitive PSA estimation?
No.
No? Okay.
Where the
Fine.
biomarkers help us,
So we'll
I
go
don't
to the
know.
next question.
Yeah, I'll just follow up. Where the biomarkers help us and what we see, we have an issue with the MRI is very hard for the radiologist to read. Quality is an issue. So, and we see differences between radiologists and hospital and health systems. So, MRIs, are not perfect, and it's very hard for the radiologist to read them. So we don't see, like, you look at the data that's published from England or New York, very high level. We don't see that in the community or in most hospitals, we don't see that level of quality.
Dr. Sarkar?
That's quite true here also. So, sorry, I think that's quite true here also. The MRI, I mean, there is a lot of variation between the radiologist in institutes and the periphery. So we get a lot of false positives. But at the end of the day, I think if you have significant prostate cancer, probably we should pick up it in the MRI. So whoever the radiologist is for like real significant lesion. So
yeah, it is a useful investigation. Anything, Dr. Sarkar, you want to add anything to this?
No, I just wanted to ask a specific question. What is the contemporary approach amongst our colleagues about approaching patients with an elevated PSA and negative biopsy? Now, how can biomarkers help in this situation? And rebiopsies, and if rebiopsies are also
there is a diagnostic role for the PSA. Yeah, then you should go for concentrated biopsy. What is your protocol?
Yeah, I think we would again go back to the biomarkers to rebiopsy someone. You have to have very good reason, and PSA alone generally is not a good enough reason. So it has to be an MRI finding or a biomarker positivity or a high abnormal biomarker. The only time I heard someone mention saturation, that's like a last resort. If the guy's PSA keeps going up, MRI is negative, biomarker is negative, but you really believe, or that's when you would consider a saturation. But I think going back to your question is you have to have a good reason. PSA alone is not the best reason.
Go for it. Okay. Okay, shall we go for the next question, please? ADT alone in high-risk non-metastatic prostate cancer. Dr. Sarkar?
No role. No role. These
alone has no role.
There's no role for it. That being said, your question is great. Is what percent are still on it? There's a large percentage. It's 60-70% in the US are still getting that.
70 we used to give them, yes, because that was the only treatment available. Nowadays we don't.
You shouldn't, but it's a bad habit that we all have to.
Next question.
Yeah.
Yes. Okay. So what are the suitable choices in the scenario mentioned below? Metastatic HSPC, high risk, high volume disease. So what are the treatment options we have? Dr. Neeraj?
I think metastatic high risk prostate cancer, high risk, I think the dual therapy will be the treatment of choice. That should be the docetaxel along with the abiraterone, or maybe docetaxel along with the maybe other agents as well, enzalutamide, apalutamide, not a single agent alone.
Any parameters you will consider before starting this treatment?
Basically, the high volume disease, definitely.
Any difference in synchronous or metachronous tumors?
Yeah, there's huge
Dr.
difference.
Kishore?
He's muted.
I think in the metastatic, probably hormone naive prostate cancer, lot of our like treatment like depend upon the age of the patient. Say if it's young patient, we go aggressive. If it's like an old patient, then probably even an androgen like in his 8th or 9th decade. I mean, more than 80 probably will go for just androgen monotherapy. And also the high risk and high volume. So the site of metastasis is quite important. Say, for example, if you have a visceral mets, that portends a poor prognosis. If you have multiple bone nets with impending paraplegia or like spinal mets, that again has a really poor prognosis. So, I mean, the cornerstone is again androgen deprivation therapy. In very old patients, still we go resort to orchiectomy in our place, in India. So we resort to orchiectomy, and then we can add one of these, second generation like enzalutamide or like darolutamide, depending upon that. So and then supportive treatment. I would go in that way. But in case there is a different histology, like unusual histology, like neuroendocrine, and the patient is young, then we have to go probably for chemo and no other treatment, again gene mutations and immunotherapy. So
if there is visceral metastasis, I think you will prefer chemotherapy, isn't it?
Yeah, more likely again we have to resort to chemotherapy. Yeah.
What is the protocol followed in your hospital, Dr. Jason?
Basically
this group of patients.
Yeah, so for metastatic high volume, we would prefer triplet therapy, ADT plus an oral ADT, APA, Enza, whatever, and then chemotherapy. We would do all three. But a lot of patients, age, they're not chemo ready, they're not chemo fit, they don't want the chemo. A lot of the patients will go for ADT plus an ARPI. So, chemo utilization is not high, but it is based on the ARASENS and the PEACE-1 data, very effective. As well, and the other thing that's important too is how these guys present is very critical. De novo metastatic disease is much more aggressive than recurrent disease. So the classic triplet therapy patient is youngish, 60s, those are the guys we aggressively treat. The 80, 90-year-olds, they all get ADT plus an oral. In our practice, 82% of the patients, we track it, will get ADT plus an oral with castrate-sensitive prostate cancer.
Okay, with this, we will go to the next group of patients, metastatic CSPC, high risk, high volume. And the patient preference is not for chemotherapy. So what are the options we have? Dr. Sarkar?
Yeah, I'm sorry.
I think if the patient has metastatic HSPC, high risk, high volume, and the patient's preference is not for chemotherapy, I would probably opt for ADT with abiraterone prednisolone. And I think that would be my approach.
Will you add radiotherapy or PSMA ligand or immunotherapy?
Not really at this stage. As HSPC, high risk, high volume patients' preference is not for chemotherapy. I think ADT with abiraterone and prednisolone for large volume disease, unless there are special contraindications, in which case enzalutamide.
how do you choose the newer anti-androgen? Which agent you'll use? I mean, you have any guidelines or
Generally,
specific preference for certain drugs?
in my practice, the elderly patients or patients with go for enzalutamide. There are some contraindications with patients with a history of seizure disorder and similar things. So, but otherwise, the side effect profile of enzalutamide is better. But I think my understanding of the literature has been up till now that for really large volume disease, a combination of abiraterone and prednisolone carefully managed gives good results. So long-term results are survival.
Dr. Jason, your comments on this?
I agree with the last doctor. You know, all the drugs are good. I mean, you're picking the drugs based on the side effect profile or the comorbidities. They're all very effective. In the US, they're very expensive, so cost, you know, becomes an issue in coverage. But Abi versus Enza versus APA versus Daro, it's really choosing based on the patient's comorbidity. Typically, patients who have a lot of cardiac history, we don't use abiraterone in. Like was just mentioned, in patients who have a seizure disorder, obviously contraindicated. And then any neurologic process, we try to switch or use darolutamide. Darolutamide doesn't cross the blood-brain barrier. So there's less CNS,
yes.
CNS depression, but I think we can say they're all effective. They're all powerful agents. You know, it's really kind of what the first doctor says based on, you know, comorbidities and potential side effects.
Any use of this PSMA ligand in this group of patients or immunotherapy, T? No,
it's not approved. We have trials, not in sickle cell T, but it's not approved. It's basically doublet or triplet therapy is the only thing that's approved. There are trials looking at radioligand in this space. There's a trial we just opened that is looking at PARP inhibitor in this space, but not right now. Nothing's approved.
Okay. Okay, with this, let's go to the third group, the low volume de novo presentations. What are the options? Radiation, chemo, or oral agents? Dr. Kishore? No, I think you're mute. We can't hear you.
No, for the low volumes, I think probably if it's outside the pelvis, I will opt for definitely radiation and hormone treatment along with that. And possible chemo or oral agents. I mean, everything in the basket, I would say. But if it's limited to the pelvis, even the lower paratic nodes, I try to clear it surgically. I do a radical prostomy and extended node dissection, even the lower paratic, and then combine everything with all options like chemo, oral agents, everything together.
Okay. Dr. Neeraj?
I think the low volume disease, we should give the ADT along with we can give the primary directed therapy, either to the radiation to the prostate along with the lymph node area in the pelvis, and usually it should be intensity modulated radiotherapy so that it can not harm the other organs like the bladder and the rectum, and you can effectively treat with the prostate and the node along with the ADT and
Dr. Rana?
Yes, I also agree
opinion
with that.
About this?
Yes, so for the low
patients?
volume limited disease, multimodality would be my choice for these patients. So if it's oligometastatic kind of thing, very limited, I'll offer the robotic surgery along with the hormone therapy, limited 1 year or 2 year duration. Sometimes RT along with the ADT for 1 year. That will be my approach. If it's a metastatic disease, and low volume and a young patient with good performance status, then still I'll offer the doublet or triplet therapy for these group of patients. And combination of the chemotherapy upfront for the low volume also gives in a younger patient, actually, specifically. So it's actually, we have to tailor-make the treatment for the patients and risk stratifications. So all the options available, we have to use wisely for these patients.
Okay. Dr. Arora is there? Hello? Okay. So can we go to the next question? Dr. Gaikwad, can we go for yeah. Now choosing initial post AR inhibitor use. You have exhausted the AR inhibitors, the docetaxel previously in metastatic HSPC, now with metastatic CRPC. What are the options you have? Dr. Kishore?
I think then there might be a role for a lutetium therapy when you have exhausted all the options. And of course, at this point, you can look for genetic mutations and then go for PARP therapy and immunotherapies. So that might be a good idea.
Yes. Dr. Jason?
Yeah, I agree with that last physician. That would be the standard. The other option too is Jevtana. Cabazitaxel is another chemotherapy agent, but in this patient we would try to get this patient lutetium and check him for a PARP.
How bad is the toxicity of cabazitaxel?
It's actually not that bad. It's not that bad.
Not bad.
Not bad. It's not bad. But most patients don't want it.
Yeah. Dr. Kalyan, any opinion difference? Dr. Kalyan?
The only thing I would add, I forgot, is we would look for any targets for radiation. So is there any areas that we could radiate?
Yeah. Or you can use CyberKnife for selective metastasis if it is it possible?
Yeah.
Yeah. Now the second one is exhausted AR inhibitors, docetaxel previously in non-metastatic HSPC. Now patient has metastatic CRPC. So what are the options? Dr. Jason?
Yeah, I think it's the same. We're looking at the same, options. PARP.
Same thing.
Same PARP.
Yes.
Radiation, Jevtana, or lutetium.
Yeah. Any difference of opinion? Dr. Kishore, Dr. Neeraj, Dr. Kalyan?
I think you can use the stereotactic body radiotherapy in the
yeah, that's one CyberKnife you can use. CyberKnife.
Yes,
you can use selectively for
or stereotactic body radiotherapy.
Okay. So shall we go to the
It's not the role of.
Can we change over to next question, please? Pardon? The treatment compliance and treatment monitoring. Treatment compliance in PC, what are the issues? Whether longer ADT injections can help? Dr. Sarkar?
Yes, I think for many years, for almost 35 years, we are using LHRH analogs. And I think there's a lot of compliance in 3-monthly injections. It gives a good interval to assess patients' response to therapy and combine the 3-monthly injections with a clinical follow-up. So it's actually been a preferred modality of treatment. But when the 3 months extends to 6 months, then I think that's a bit of a long time, especially in patients with metastatic CRPC I think things may change in 6 months, and there should not be a with widespread metastatic disease, patients with bone pain, anemia, and other issues. I think the 6 monthly injection may give the patient a false sense of security. So I think the 3 month follow-up, 3 monthly dosing is very practical, and safe for patient follow-up. That's my take on.
Do you consider cardiovascular status of these patients before continuing? Do you consider cardiovascular status of these patients before continuing these ADT injections? And have you used the antagonist?
There has been a lot of noise about cardiovascular side effects of these molecules, and but the data in the literature doesn't actually confirm a big advantage. But I think the antagonists are very useful in patients who have widespread bony metastatic disease and threatening obstruction of the upper tracts. And these are situations where I actually prefer the antagonists or do the good old-fashioned orchidectomy straight away. So I think I certainly would avoid using an agonist in these situations. Regarding the cardiovascular safety issues,
definite high risk with cardiovascular disease.
Sorry,
I agree.
There's definite high risk with cardiovascular disease in all the ADTs.
With all the ADTs, but I agree with Dr. Sarkar. Yeah. The literature is not clear, and I don't really buy into the cardiovascular risk, agonist versus antagonist. There is cardiovascular risk for all of these drugs. I don't think there's a benefit from the antagonist. That's not clear. We've actually studied it. We don't see it, and you can look at the Orgovix trial that was done with the oral antagonist. They saw in post hoc analysis some benefit, but the trial's flawed. It's not. I don't think it's real. But there's a lot of noise, and we just had to close a trial that no one can figure out a way to show that it's real or not real. So there's just going to be noise, like Dr. Sarkar said, for a long time. I agree also with Dr. Sarkar said is that we use the 6-month shot because it's easy and convenient and we have less breakthrough, but we still have to see these patients every 3 months because, in these late stage patients, the disease can change too much. And sometimes if they're very symptomatic, we'll see them monthly. I think the key here too is that these patients are evaluated with laboratory PSA and testosterone every 3 months at least. And if they start getting really sick, we'll bring them in monthly.
Do you do sequencing, starting with antagonist and later on to agonist?
Yeah, everybody gets everyone gets 2 months of Degarelix, and then we transition them to Eligard. So we because then we don't have to write for biclutamide. We don't have to worry about flare. But everybody gets Degarelix, then Eligard.
So you prefer Eligard or the Zoladex or the Gasoline?
We only use Eligard.
Out of
we use Eligard. It's a sub-Q injection, and if you look at the data, there's no data to you can't say one's better than the other. But you look at the Eligard data, it's their testosterone levels are always in the single digits. You don't see that with a lot of when you look at these studies. I'm not saying one's better than the other. It's just what I see when you really look at these studies. Eligard's easy to use. The 6-month is nice. But yeah.
Any of your patients are on continuous antagonist for a long time?
Oh, long time. Well, yeah. We don't do I was when I was meeting with I have never done an orchiectomy. I mean that we just, and I know in India, I looked this up, it's 30 to 40% of orchiectomy still standard care. I've never done it for advanced prostate cancer.
It's basically for the compliance.
Yeah, I mean, it's a different. I'm not critical. It's just a different. So we use these drugs forever. I don't know if it's right. An orchiectomy, when you look at orchiectomy, the testosterone suppression rate is probably better. Not I want to say better, is equivalent to these drugs, but it's not
Fantastic it is.
it's not reversible. It's just in the US, I don't know, we've made an orchiectomy like the worst thing that can ever happen.
Okay. Okay, the next part is the treatment monitoring. How frequently you do monitoring? What are the parameters monitored at various stages of the disease? Dr. Neeraj?
I think the
How
only treatment
frequently you
monitoring,
monitor these patients?
we monitor mostly with the PSA these patients, as well as with the imaging technique like the
How
PSMA
often?
PET. Only two things we monitor. One is the
How
PSA
often
and
do
the
you
other
do it?
thing the PSMA PET.
Well, how often? I'm sorry.
Dr. Rana?
Yeah. Oh.
Yeah, go ahead.
So actually, we monitor these
Anna?
patients with PSA, serum PSA. Am I audible? Okay.
Yes.
So we monitor these patients with the serum PSA levels. And nowadays, with the availability of Eligard 30 milligram once in 4 month injection. So as majority of our patients, they come from outstation. So once in 4 month visit is more cost effective also for them. And I find it reasonable in terms of the monitoring as well as the efficacy of bedside. For 1 year, there are 3 visits, and I don't see any harm in reducing their 1 visit extra. And the PSA monitoring gives us significant idea about the disease progression. If there is increment of the PSA, then PSMA PET CT. So these are 2 things important for our monitoring of these cases.
One thing that is not made the NCCN guidelines, but if you look at ARCHES, you look at Titan trials, there was just a nice article from Asia somewhere, from a Chinese or Japanese, that there is a concept that we're seeing of PSA discordance. So the PSA is not progressing.
Disorders.
PSA 0, that they're still showing radiographic progression. So what we try to do on top of everything that's said is image them regardless of PSA, regardless of symptoms. It can be conventional CT bone or PET, but you still want to regularly image these patients while they're under therapy, regardless of the PSA.
Any of your patients of adenocarcinoma, have they migrated to small cell or neuroendocrine tumors?
Yeah, definitely.
How often that is seen?
We see it.
Actually, once in a year, PET CT imaging we are doing in our practice.
Now, how often you see these patients? Migration from adenocarcinoma to neuroendocrine tumors?
You see it late stage, usually when you see a liver metastasis or sudden visceral mets, that they progress rapidly. You see it like 5 to 10%. The guy will be fine,
Okay.
and all of a sudden you'll see a big liver.
That's pretty large number.
Yeah, you see it. Because these guys are living a long time, and then eventually some of them will just like convert really fast, and it's always shocking. But that's why you have to image these people. Maybe you can catch it because
can we go to the next?
Their PSA might not change.
Yes, frequently, yes. And the biopsies as well?
Yeah.
Okay, next question is cardiovascular safety. AR inhibitors, how do you monitor impact of same on your prostate cancer patients? Dr. Kishore, your comments?
No, I don't routinely monitor the patients on AR inhibitors or any other form of hormonal treatment unless they don't have any cardiac symptoms. But I do get occasional MIs of these patients like on hormone treatment. So unless they don't have any pre-existing illness, I don't routinely monitor.
Okay, Dr. Sarkar?
Well, I do. I think this day and age, actually, you've got to counsel the patient when you start androgen deprivation therapy, that this may have implications on your coronary disorders. So I think it's always very wise, and it's recommended to actually get help before you start it. So I don't usually monitor this personally, but you will have certain patients who will have volume overload. They got to find out subtle signs of cardiac failure. So it's always good practice to check to have a sort of a holistic approach to your patient. But I think they should all be warned that they're on androgen deprivation therapy, which can abnormally affect patients' lipid profiles and cardiac status, and that they need cardiological follow-up.
Suppose there is a patient on ADT, and if it develops any of the cardiac events, what do? You stop the medication or shift to what? What are your options?
That's a difficult question. But I have seen patients die of progressive patients with bad, poor ejection fractions and all getting worse after ADT. I think if there's a problem, then we may have to even shift to perform an orchidectomy, or perhaps shift to I don't know if Degarelix is useful, but I would probably consider stabilizing the patient's heart, and if the patient once he's cardiologically stable.
The incidence of cardiac events, whether you do surgical orchidectomy or medical orchidectomy, is almost the same. So by doing surgery, you're not going to support it.
I suppose so.
What is your opinion, Dr. Jason?
Yeah, I think, I'll start with your first question. Is cardiovascular disease with these drugs is a significant risk? In our patient population, they have to see a cardiologist, and or at least be evaluated by their primary care physician. Most of these events occur within 6 months of starting these therapies. There's not much to do but to maximize their cardiac risk. Their blood pressure is controlled, their cholesterol is controlled. If they have pre-existing cardiac issues, those are treated. And then most of the time, you want to get it treated before they start their therapy. But I think it's communicating with the primary care doctor, communicating with the cardiologist, saying, is this guy's maximized? The only thing that has shown benefit that's published in the literature is metformin. The use of metformin in this patient population is effective, but reality is no one really does it, but it's probably underutilized. In a patient that has a cardiac event or a MACE while on therapy, we just keep treating and just tell the cardiologist and the medical guys you gotta maximize his cardiac risk.
Okay, we'll go to the next question. Dr. Gaikwad. So future consideration, ideal patient for triple therapy in clinical practice and real world consideration. What is your opinion about triple therapy, Dr. Kishore?
I think it's quite effective. I think many of our patients fall into that category. So I think more and more we should be utilizing it, especially in people in their 60s and 70s and 50s. We should be practicing it for
low volume disease or high volume disease?
Even for high volume, I think we should be practicing.
You prefer in low volume?
Low volume also, both. But like probably its effect is going to probably maximum in the low volume disease rather than high volume. But I think in both conditions, I think we should be utilizing that.
Dr. Neeraj?
I think we should prefer the triple therapy with the younger patients, as well as in both low volume as well as high volume disease.
Okay. Dr. Rana?
Yes, sir. I also agree that for the younger patients, we should give the benefit of triplet therapies, and definitely for the high volume disease. So we have seen in our practice also there is significant improvement and the stability of the PSA response in this group. They are effective and we should use that.
Dr. Jason?
I agree with everything said, but it's primarily high volume, de novo, chemo fit, which is younger, healthier patients. That's the triplet patient.
And the last question, which trials are likely to change the treatment practice in cancer prostate? Any comments?
I do a lot of trials I've been involved with most of these trials for the last 10 years. I think the big ones that stand out that I'm excited to see is Proteus. The Janssen trials, Johnson & Johnson is Proteus, which is ADT plus apalutamide, 12 months post prostatectomy. That will be out next year. Atlas is another J&J trial, which is ADT plus apalutamide and radiation for Gleason 8. The Stampede data was too extreme. And then anything with radioligands is interesting. I think the PSMA4 and PSMA addition are really going to be, are really exciting.
Anybody wants to add anything in this?
I just had a question to Dr. Jason. So if you are placing the patients on ADT after radical prostatectomy, now beyond 1 year, once you stop the ADT, what will be the erection status generally, in case you have done a nerve sparing? So
yeah, it's a problem. Erection status is going to be limited. It's going to be a 1-year recovery, and that's why it's really important that this is just for high risk. This is not for everybody. And in the publication or the trial I showed you, 60% of those patients were Gleason 9s. So these are the very 15% small, like the bad cancers where you can justify it, that patient may have significant ED for years to come because that guy has lethal prostate cancer. So it's not for everybody. It's not for your 7s. Or, it's the bad cancers. Because when you look at the literature too, from all the trials where they tried to do neoadjuvant and adjuvant, they were all negative. They didn't work. And that's why we routinely don't do it, is they were treating, they had some intermediates in there, they had some not so high risk. But if we just focus on those high risk patients, the really bad ones, that's the guys who need it. And that you can justify that you will have significant erectile dysfunction because that's lethal prostate cancer.
Any development in prostate vaccine? That ProVax study?
The vaccine.
Prostate vaccine?
Yeah, no, it's been negative. The Prostavax, it was called Prostavax. It was made by a Nordic company. The company was called Nordic. It was negative. Not there.
No use. And this PSMA bite treatment?
I'm sorry?
It didn't work?
No.
PSMA bite.
Oh, which one?
PSMA bite, B-I-T-E, bite.
Oh, BITE. Yeah, BITE technology is interesting. It's being developed by Amgen. I saw their phase 1. They're in phase 2 now, where they use immunotherapy to the PSMA molecule, to the PSMA receptor. The only thing that's scary about that, I don't know the efficacy, but these patients have a massive inflammatory response where they have to be admitted to the hospital. So it's a little like, because we were offered that trial and I looked, it's like an inflammatory storm of some sort. I was kind of scared to do it. It was too much for me. So maybe in their phase 2, phase 3, they'll be a little safer, but right now it just seems a little intimidating.
Okay, good. Next question. That's that finished.
Yeah.
It was wonderful to be with you, Dr. Jason. And your opinion plays a lot of role, especially in our treatment program, and that will help us in our clinical practice. So thank you, everybody, Dr. Neeraj, Dr. Kishore, Dr. Kalyan, and Dr. Rana for joining this
Thank you.
particular panel
This was
discussion.
really fun. I don't get to do this very often, but this was fun. Thank you so much for this opportunity. Thank you, mCure. Really appreciate it.
Yeah. Thank you so much.
Thank you, everybody.
Thank you.
Pleasure to meet all of you.
Good night.
Thank you so much, Professor Pisa, for moderating the panel, and all the
Bye-bye.
panelists for their time and wonderful discussion. And thank you to Professor Hafron for being in this meeting and sharing the wonderful insights. I am sure that the attendees of this webinar have given the expert insights in the treatment of prostate cancer with the help of all experts who have joined today in this meeting and staying back long for this meeting. So thank you from mCure team, and thank you everyone, and good night.
Thank you.
And good day to
Good
all.
night. Good
Good
night.
night. Bye-bye. Good night.
Thank you, sir. Thank you.
Good night.
Bye-bye.